everyone, and welcome to our webinar this afternoon, Big Data, a Starring Role in Healthcare Information Architecture. Just before we get started, we have a few housekeeping rules or issues. All the participants are muted, and the audio and visual is done through ReadyTalk. If you have any issues at all, please go to readytalk.com, and they will have a customer care person to help you with whatever issues you're having with either the audio or the visual. So just a few words about eHealth Initiative. We've been around for about 17 years now. We're a multi-stakeholder collaborative from across the healthcare ecosystem, really having discussions with people from across the spectrum to discuss how to transform healthcare through information and technology. 2014, the members got together and developed the 2020 roadmap, and our initiatives now are focused on this roadmap. We are focusing on interoperability, privacy and security, business and clinical motivators, data and analytics, and also innovation with our new resource pages that are in development. This webinar was made possible through the generosity and support of PHEMI, so we want to thank PHEMI for this fabulous webinar. And on that note, I'd like to introduce our moderator for this webinar, David Foster, who's the Vice President with HealthWise. David?
Thank you very much. I am with HealthWise. Our nonprofit mission is to help people make better health decisions. We've been members of eHI for many years to advocate for patient-centeredness and health IT standards and policy. And I'm excited to moderate this presentation today because as we work on data issues in health IT, we run into a lot of efficiency problems. How do we provide data to scientists and analysts who look at the data to show that we really are helping people with our mission? And how can my team spend less time cleaning data and moving it around, de-identifying it, and making it available to others? So looking forward to this discussion today to all learn about how we can address some of these issues. So first, we'll be hearing from Dr. Trent Rosenblum, who's the Vice Chair for Faculty Affairs and Associate Professor of Biomedical Informatics with secondary appointments in medicine, pediatrics, and the School of Nursing at Vanderbilt. So we'll hear about a PCORI project that's going on there. Very excited to hear that. We'll also be hearing from Kirk Kirksey, who's the VP and Chief Information Officer of University of Texas Southwestern Medical Center. Hopefully we'll hear about some of the challenges that they've overcome there with combining a lot of different data sources and health centers that they're managing. And then finally, we'll hear from Dr. Paul Terry, who is the CEO and CTO of PHEMI Systems, our wonderful sponsor of today's event. So I would like to hand things off now to Dr. Trent Rosenblum.
Hi there. Good afternoon. Making sure everyone can hear me.
We're good.
All right. Good afternoon. Thank you for the opportunity to talk. I'm going to present to you over the next few minutes some of our experience bringing data together in support of a large multi-site research initiative that's funded by the Patient-Centered Outcomes Research Institute called PCORI. Next slide, please. So PCORI has within it a group called ProCoreNet, which is the National Patient-Centered Clinical Research Network. And the goal that ProCoreNet has is to develop an infrastructure to make it faster, easier, and less costly to conduct large-scale clinical research across multiple sites. And doing so leverages existing data and also patient partnerships. That's the patient-centeredness that is really prevalent throughout all aspects of the work that's being done. Next slide. Next slide, please. Thank you. So the work we're going to talk about this afternoon is the result of ProCoreNet's aims to create what they're calling a network of networks. Each of the networks themselves are small, focused networks, either geographic or disease-focused. And then ProCoreNet hopes to bring them together in this network of networks to support cross-network research. Networks, the smaller networks are each built through partnerships among patients, clinicians, health systems, and others, including disease advocacy groups. Over the course of setting up ProCoreNet, the organization seeks to transform the entire culture of research to one that's directed by, from one directed by researchers to one that's really driven by the needs of patients and other healthcare stakeholders. ProCoreNet itself includes 3 organizations. One is called the Coordinating Center, which I won't talk about today. One is called Patient-Powered Research Networks, which I won't talk about today. And one is called Clinical Data Research Networks, which is what we'll be talking about. Next slide, please. So when PCORI funded in Phase 1 and Phase 2 CDRNs, or Clinical Data Research Networks, you'll see that they funded them to cover sites across the country. Our site, which is called the Mid-South CDRN, is represented in the black dots with a big fat one right in the middle of Tennessee, but you'll see them throughout the Mid-South. Next slide. So clinical data research networks are networks that originate in healthcare systems, and they're designed to collect health information that's gathered during routine clinical care of patients. It's generally not set up to gather new data, though you can use the ProCoreNet infrastructure to do that. There have been 2 phases. The first is really the infrastructure building phase. That included 11 sites, and that took place through about this time of year last year. And we're now in the middle of Phase 2, which will continue on till the end of September in 2018. Phase 2 added 2 additional sites for a total of 13 ProCoreNet CDRN networks. Next slide. So the initial goals of the CDRNs, this is going back to the beginning of Phase 1, was to be able to engage at least 1 million patients across 2 or more health systems. And as I'll show you in a moment, we have numerous health systems involved in our CDRN, but some of the others only have 2 or 3. Then to build an infrastructure that will allow data sharing, including leveraging and building novel informatics tools, and as I mentioned before, to engage key stakeholders to guide the whole process throughout the process. And then last, to use this infrastructure to perform honest-to-goodness research with a focus on comparative effectiveness research and pragmatic clinical trials. Next slide. So this is the Mid-South CDRN. It is centered out of Vanderbilt. Vanderbilt is a large tertiary and even quaternary care center situated in Nashville in the middle of Tennessee. Vanderbilt has affiliations with the Meharry and Metro General Hospitals, which provide services to an underserved community in Nashville. Vanderbilt refers in from throughout the Southeast for some of its tertiary and quaternary care. And Vanderbilt has about 2 million patients. Our second partner is VAN, which is the Vanderbilt Health Affiliate Network. The H is silent, and while Vanderbilt is in the acronym, Vanderbilt is only one of many, many players. VAN is an affiliate network that covers sites across Tennessee and in the states just around Tennessee, covers over 34 hospitals, it covers over 350 clinics, and it engages over 3 million patients. Next is Greenway. Greenway is a health information technology provider that has within it a practice-based research network. Greenway as a whole engages 14 million patients. The practice-based research network is a much smaller group. And in Phase 2, we added sites across the Carolinas including Medical University of South Carolina, Duke, UNC, and the Carolinas Collaborative, covering over 6 million patients. Next slide. So in phase one, we had a number of key milestones all centered around patient engagement. This really restates what I said before, that we want to build a large infrastructure. We want to have large-scale enrollment of high numbers of patients. And then we want to invoke novel informatics solutions. On this slide, I include listing efficient biospecimen banking, which is something a couple of our sites do, ultimately making that data available for large-scale research. Next slide. So the initial plans from phase one, and we're doing this still in phase two, was to build up at least 3 cohorts in each CDRN. The first was called the Healthy Weight Cohort. This is 10,000 individuals to study weight-related issues. I believe the name has changed, and I don't have the current name. But the idea is really to use this large-scale cohort in each CDRN to study ProCoreNet-wide issues around healthy weight. Each CDRN was to select a high prevalence and a rare disease. For our CDRN, we selected coronary heart disease, and we have a goal of recruiting 10,000 patients. We're well on our way. And our rare disease is sickle cell, and we've recruited 400 families of individuals with sickle cell disease, all contributing data to the network. Next slide. So ProCoreNet, from up on high, though with patient engagement and stakeholder input, set up a common data model that has several axes of health-related and demographic-related data that they expect us as partners to standardize according to their standards. Many of these standards replicate standards we're already using. For example, diagnoses are coded to ICD, condition is coded to SNOMED, etc. And if you go on to the next slide, there's actually a deeper dive data model that we work with to help us encode and structure all of our data. Next slide. And all of that is available on the ProCoreNet websites for download. The goal then is for each site within our CDRN to build its own data mart, though they could ship it to a central site if they chose. That's not how our sites chose to operate. Each of them standardizes their data to the common data model, standard and structure, and then they put a top at PopMedNet, which allows queries. Queries can come down from ProCoreNet, so ProCoreNet can send a query to all of our sites saying, tell us how many patients you have with a BMI over 40. And they can plug that query into their PopMedNet. It queries their common data model, and they get an answer back very quickly. Local governance can then decide what kind of oversight they want and when and how to share that back up to ProCoreNet. Next slide. At Vanderbilt, we have an infrastructure underneath our common data model that I want to spend just a moment talking about. This is really built off of tools that are available from REDCap. What we do is we take all of our data, all of our clinical data in our EHR, and all of our demographic data and other relevant data. We run it through a filter which includes some manual curation, but also includes just a lot of simple standardization algorithms, and put that into our research data warehouse. Our research data warehouse has 2 sides, an identified side and a de-identified side. The de-identified side allows for more efficient research for those people who don't need PHI or protected health information identifiers. But we also have an identified side. All of that then can feed downstream research efforts, and so we use that to feed the relevant data that are in the CDM to our CDM instance to support queries that might come through our PopMedNet. But it's also useful to support other research efforts that are in place. such as a local record counter. Anyone at our institution can log into a simple interface and do a self-service count to identify patients at our site with a BMI over 40, for example, or with the diagnosis of coronary artery disease. Next slide. There are a number of other linkages we've been working towards to complete the data that's in our CDM, including Tennessee State Health Department data, TennCare data, CMS data, insurance coverage or our health plan data, data from SureScripts, which is the infrastructure we use to route e-prescriptions, and other sites. Next slide. We are required to do frequent updates to the Common Data Model instance. It's not done in real time. It's done quarterly or every 6 months. And this slide really just shows you the frequency with which all of the Mid-South CDRN sites do this and the number of encounters and patients they contain. You can see we have over 1 million at most of our sites. Next slide. We also have to do data characterization. That's where ProCoreNet sends us simple queries to test our data to make sure it is in fact standardized and our infrastructure can support these true research queries as they come down the line. And so we've done a phase 1 study, and most of our sites were research ready. 2 of them were closed. Next slide. We're about to undergo a second stage of our data characterization, which looks deeper into our data model. And this begins in a week, 2 weeks actually. Next slide. So talking about from before some of the other sources of data that we want to link, this slide provides a high-level overview of some of the work that we've actually been doing towards getting the data linkage, where we've actually succeeded with data linkage, and the dates of data that we've got covered. So, for example, we've been able at our Carolina sites to get North Carolina Medicaid and South Carolina claims. We've been able to get some TennCare claims, and some of our health plan claims are in process. Next slide. We have a series of novel informatics tools that are built in the REDCap tool set, and we've been slowly integrating these into our data infrastructure. One of the ones we're very excited about is we have reached out to all of our Vanderbilt patients who have a patient portal account and asked them if they give us permission to reach out to them directly with research opportunities, which sidesteps the HIPAA research rule, which requires such research queries to come via one of their healthcare providers. And we sent out 300,000 requests. So far, 20,000 have agreed to be contacted directly by phone or email to participate in research. Next slide. Last thing I want to talk about today is the first ProCoreNet-wide pragmatic trial. It's called the Adaptable Trial, the aspirin dosing, patient-centered trial assessing benefits and long-term effectiveness. And the goal of the Adaptable Trial is to evaluate 2 different doses of aspirin for prevention of strokes and coronary artery events in individuals with heart disease. The 2 doses are 81 milligrams a day and 325 milligrams a day. There's no clear data on which one is safer and which one has a better safety to risk profile. And so this is a large-scale pragmatic comparative effectiveness trial funded by PCORI, and it's the first large-scale ProCoreNet demonstration project, and it's just now underway. Next slide. The goal is to recruit 20,000 individuals and to use, in as much as possible, CDRM infrastructure across multiple CDRMs. Next slide. So I put the question slide here, but by the nature of this panel, we'll save those to the end. I appreciated the opportunity to talk, and I believe Kirksey is up next. Yep.
Hi, this is Kurt. Thanks for letting me present today. I'm a lowly CIO in a medical school, so everything is my fault when it doesn't work. I'm involved with big data, but I'm also medium-sized data, small data, all data. So next slide, please. I want to talk a bit about Southwestern, how we use our clinical data, how we use the information, and how we want to use the information in the future, and really what I see our biggest barriers are. When I say our, I mean sort of the royal our, not specific to here. Next slide, please. Southwestern is not a hospital. It's an academic medical center. That means that we really have three missions: patient care, research, education. We have 40 clinics, which is an example of data standardization. What's the definition of a clinic? Sometimes that's hard to define. We have 14,000 employees and overall about a $2.8 billion operating budget. We are closely affiliated with Parkland Hospital in Dallas, the county hospital, Dallas Children's at the Dallas VA. Last year we opened Clements University Hospital. You see a picture of it there on the right. Looks like a W looking down on it. We've just formed a partnership, I think one of the first public-private partnerships with Southwest Health Resources, which is a very large health services provider in our region. Next slide, please. Next slide. Nope. One back. Yeah, this is a bit about the information resources, our information technology department. I won't read all of it there. You can see the stats. I will say that from a automation point of view, we are pretty advanced. We're recognized as most wired. We have reached level 7 designation by the HIMSS organization, and this year we won the Healthcare Informatics Innovator Award. We were first place with some quality work that we did in our clinics. Next slide, please. So this very simplistic little picture sort of demonstrates where I think we have been and where we are. We started way back in the 50s where the mainframe controlled everything. The pendulum shifted sort of in the 70s, 80s, and 90s to this idea of best of breed. So the idea was that you would go out and buy systems that provided the maximum functionality for your business units. And so hence we've ended up with units with operating computer systems in all kinds of hospital and clinic departments. I think what we see is a swinging back of the pendulum, and the industry is placing more and more value on the integration, the true integration of data. So I think what you're seeing with the big architectures and systems and products like Cerner and Epic are that data integration is really beginning to trump functionality. So we will now sometimes say we're not going to buy a separate lab system, that the integration is we're going to go with the products that we have. And as a result, I think we can all agree that the electronic medical record is probably here to stay. You can credit it to the technology or Obamacare or high tech, but I think after 25, 30 years of struggling, that we can all agree that we are EMR bound for healthcare from now on. Next slide, please. Well, in our case, and I think a lot of other cases, you can talk about the electronic medical record and what it does, but one thing it does in terms of data is it's now our main data aggregator. That's where a lot of the interfaces, as you all know, go, and so hence that's where we go to get a lot of our data for analytics. The good thing about that is there's a lot of data there to get, not just data from the traditional business unit sources, ancillary sources, but also non-structured data, nurses' notes, clinical documentation, things like that. This gives us a path to patient engagement We can certainly control some of the quality of data through this workflow, and it has a very patient-centric organization that's used for treatment. The not-so-good side when it comes to data is the EMRs cannot collect a lot of non-clinical data that we are interested in. We would like to collect, for example, a lot of output from building systems in hospitals to see if we can run air conditionings and elevators, things like that more efficiently. It really doesn't capture a lot of metadata that we would like to see, for example, from instruments, infusion pumps, reagents from lab. It's very basic in what it collects. From our point of view, since we have two of our missions is research and teaching, the EMRs are really research and teaching challenged. They are, in some ways, involved from billing systems and reporting results. And so, when you're trying to integrate these into your research and teaching program, it can be difficult to do. And one downside of research may be that it is patient-centric, where you need to organize and manage your data differently than being strictly patient-centered, for example, around cohorts, as the previous speaker mentioned. And really, when it comes down to big data, it is really not engineered for big data yet. In terms of diagnostic imaging, genetic sequencing, we are in the process of trying how not to integrate those into our EMR, but to connect them on the outside, make that kind of big data accessible. Next slide, please. So how we use the data from our clinical sources is we have a electronic data warehouse that really began as a CDR, clinical data repository. However, we took the architecture of that and expanded it enterprise-wide so that it really has become an integration point for lots of systems, including our ERP, our learning management systems. We built it ourselves on a Microsoft platform. It's digital. And we have another database, we're a I2B2 or a CTSA grant holder, which is a Clinical Translational Science Award. And part of that award is you must be able to share data with other CTSA sites. So we have a second repository built on the I2B2 data schema out of Harvard. We use the information for teaching. We have adapted our electronic medical record platform to a certification program at a local university where I teach using our non-production environment of our EMR. So our students become certified they understand how to produce an order set and what workflow looks like. And in turn, we like to hire those students into our department. We are putting in a new learning management system now and setting up teaching patients that will simulate care for our medical students. For research, we ship a lot of this data to our researchers. Of course, the IRB protocols are in place for this. We have integrated for our clinical trials. We have integrated our electronic medical record system, which is EPIC, with our clinical trials management system, which is VELOS. I think we were one of the first to do that. So now we could register a clinical trial patient and have that information transferred to our EMR. And we like to do a lot of awesome operations research, which I'll go over in a minute. Next slide. So big data at UT Southwestern, the question always comes to mind is something like this: what is big data to begin with? If I put on my CIO hat, really big data is any data that I have to process that I can't do with commodity tools. But here at Southwestern, we sort of think of big data as the holy trinity. You've got to move it, you've got to share it, you got to store it, and you got to compute it. And if any one of those legs breaks down, then your big data program is weakened. So what we've done is we have built a series of high-speed network connections, not only to our central data center, but also to Texas Advanced Computing Center in Austin. This is the pathway where our scientists can ship big data, store big data, and in some cases process it on the supercomputers at this site, which is the University of Texas site. We do support high-performance clusters. with specially trained personnel in our own data center. For the big data, our programs, we supply a co-location, co-operating environment and a true DMZ for our researchers who want to share their information around the world, around the globe, the internet. We partner with our bioinformatics department, and we are heavily involved in the formation of a new clinical informatics program here, partner with some regional universities. As I mentioned, we are a CTSA grant holder with I2B2 Research Data Warehouse, and all of this infrastructure is baked into our disaster recovery and institutional co-location site in another city. Next slide, please. This is sort of some of the examples of research, of our operations research that we have done with this data. This is a study that colleagues and I just finished looking at, patient portal interaction of congestive heart failure patients to see if interaction with the patient portal leads to better outcomes. We have done models, readmission prediction models for CHF patients. We have looked at duplicative diagnostic imaging in the Dallas-Fort Worth region. So we do a lot of this kind of operations research, I call it, with this kind of data, in addition to clinical trials carried out by our scientists and our physicians. Next slide, please. So I'll get into a little preaching here about where we are with analytics, not just here, but I think throughout the healthcare industry. When people come and try to sell me analytics, I generally are talking about dashboards. We sort of think of our analytics with 4 peaks, these retroactive analytics. Something that I don't mean to be disparaging because I am an academic. I'm a professor at another university, but what I call academic predictive. And I've drawn a big circle around that because we seem to be sort of stuck in these two areas. Where we want to be is really operations predictive, where we can we can look at a problem, theorize that problem, test it, and then really design interventions to improve outcomes or safety or our efficiency, and then go back and test those interventions. And certainly, ultimately, something we call process analytics. We want to be able to predict, but then auto-intervene without any human involvement. And an example to me is a self-driving car. That is really the ultimate exercise in high data intensity analytics with auto intervention, and I certainly hope it works when I buy one. Next slide, please. So this is an example that I like to use with my students. The difference between just doing an experiment and doing an experiment with the idea that an intervention is possible. I'll use the example that I used earlier. We found that there is real reason to believe that if a CHF patient is highly involved with their electronic medical record through a patient portal, their outcomes are improved. That is, they don't have nearly as many readmissions to the hospital. So what I like to theorize about is what kind of interventions could we take based on this kind of information? Well, we could certainly target better training for our CHF patients. We may want to spend money on at-home support, help people get connected and stay connected. We would certainly want to train and support families and other caregivers. But things like this, these types of interventions are really what we think should be major targets of this, what I'm calling operations research. And these can be all over the board, but to do this is you really need access to the data, and you need to know how to use the data. Next slide, please. So one of the major barriers, and again, this is my humble opinion, I think, and the previous Trent really referred to this as well, and that is I don't really believe that data governance has reached its full maturity and effectiveness yet. In that, in a way, I look at the move of the federal government with meaningful use and ICD-10 as sort of a way of implementing and forcing upon healthcare a data model because we couldn't devise one ourselves. But data governance being consistent data definitions, data transformation rules, categories. When we started building our EDW, we took a look at our own data and decided the first data definitions, data standards, internal data standards we should set are clean definitions for our organization, our people, and our physical space. We found that these data elements, with all the 600 systems that we have, could be stored many different ways. And so we needed to really focus on those areas when we began putting together our enterprise data warehouse. The next thing is understand the analytics architecture. And I put a picture of my hero there, Dr. John Snow, because I have a lecture that I give to my graduate students called What Would Dr. Snow Do? And Dr. Snow was a physician in 1830 who isolated a cholera epidemic in London and determined, this was before germ theory, and determined that a specific well was the source of the cholera epidemic, but he used data to do this. Of course, it was all manual data, but the exercise that I do with my students is, if Dr. Snow brought this data to us today, what kind of architecture would we have to build so he would come to the same results? And a lot of those problems, whether it's big data, small data, manual data, data that's 100 years old, a lot of those problems are still the same today. And last but not least, I think we are very lacking in the training of our analytics professionals. We certainly teach people how to do management reports, but what I find in sort of my travels around is we need people that are really hypothesis-based in their investigation, that understand how to prove or disprove something through sound statistical testing, who write well, and who can understand process re-engineering. So I think that this new professional, this is the new frontier in healthcare. The last 10, 15 years, it has been looking for people who can run the electronic medical record and can do interfaces. But I think that we are over that hump, and now the new frontier is really analytics in healthcare. Next slide. So my last thought is, what does big data buy us? I mean, we hear about it all the time. As I said, if I put on my CIO hat, big data, I don't care so much about the content, but the big data is something that I can't use commodity tools to move around, store, or compute. If I put on my statistician hat, what big data is supposed to do for us theoretically is reduce our sampling error, because now we have all the data. Certainly big data gives us a vehicle, gives us a pathway to do kinds of data that we haven't been able to have before, such as high-res diagnostic images and genetic sequencing. I mentioned our interest in building systems output. We can certainly capture much more of the same data that we've been capturing on a much wider scale. Big data and the computing to process it gives us new pathways to presentation and simulation techniques that we've never had before, and certainly some intensive modeling. But I put these two charts up there. They're very sort of well-known big data studies. Google used big data around 2000. I think they started in 2004 to track the H1N1 flu. They used all the search terms that they felt were associated with the flu, and in fact, they missed the mark in 2013 and missed badly. And one reason they did that was, I think, that was a governance problem. That although they had lots of big data, the variability of that data they could not control. The second one that I really like is the famous Walmart big data study, where they tried to predict what people bought before Hurricane Francis, and to their surprise, figured out that the sale of Pop-Tarts was multiplied by 7. So I think we can't even with big data, we can't buy our way out of this problem. We've still got the barriers that I cited in the slide before are still there, and we still have to focus on them, and we can't assume that because we have big data that we will come to the right conclusion. And with that, I will pass it over to Paul. Thank you.
Thank you, Kirk. So I'm Paul Ferry. I'm the CEO of PHEMI. PHEMI is 4 years old. Our background is in supercomputing, distributed processing, big storage, and big networks. Next slide. So I sit on the board of 2 hospitals. I sit on the board of Genome BC and Life Sciences BC. Our goal when we started PHEMI 4 years ago was to solve the problems of data in healthcare, whatever those problems were. So there are 2 main problems with data in healthcare. This is the first one. In our hospital, there are 993 databases. I counted them. And to connect 993 databases together would require 500,000 connections. Our hospital has 10. And that 10 cost them several $100 million. So the first problem we have is all of our data, as was alluded to earlier, is actually shared in lots and lots of databases. And those databases could be EMRs, they could be devices, they could be administration databases, there could be census information. And so we see all of those data sources necessary to derive insights. Next slide. So the question begged was, how do I combine this data together for secondary use without the second problem, compromising privacy, security, and governance? Because once I combine data together, which turns out to be a relatively straightforward task, the problem is that anybody can do anything with any data, and that upsets a lot of compliance people. So this is the question. How do I share data without compromising privacy, security, compliance, and governance? Next slide. So in PHEMI, we actually make a big data platform. We use Hadoop, and then we put our magic on top of Hadoop. And this is how we see our data, which is a great big library of information. We allow people to put any information in this library. This could be genomic information, images, waveforms, documents, anything at all in this library. So this is our model, a big library of information. Next slide. The problem with this is that if I put all this data into this big library, how do I manage these digital assets? I do believe that we're in an age now where data is the new capital of the world. So it used to be that money was a capital issue of the world, and capital is defined economically as that thing that you need to actually derive goods and services. Now, money was that thing you would need to be an economic driver of goods and services. Now it's becoming data. I.e., if I have data, I can do goods and services. If I don't, I cannot. The key part of this library that I just put up, especially this library gets to petabytes of volume, is how do I index it? Clearly, in the past, libraries have index cards. We index books, for example. So a lot of what we do in PHEMI is create indexes for everything that we have and everything that we collect, including indexes of the contents of data. So if these are documents, we would index the words, sentences. If these are gene sequences, we index the SNPs. If this is voice files, we index the words in the voice files. So this creates a non-blocking switch of data that intersects all of the data. Next slide. So this is, and this leverages Kirk's point earlier, which is to turn your data into a strategic asset. The first thing to do is to collect it, then possibly transform it. Obviously, a lot of people are trying to standardize data, but the problem with standards is there's as many standards as there is data sources often. We have data sources in several customers that go back to the 1970s, for example, and they can't change that data. And so how you transform data, how you ingest it, transform it, is very important. And the last one, which I'll talk more about in a second, is privacy, security, and governance. I just came back from briefing the 2,000 ministers of the OECD countries on how you can have a digital library and how you can use it whilst protecting privacy, security, and governance. And we'll talk about that for 2 or 3 minutes in a second. Next slide. So I mentioned this earlier. We can collect anything and everything, and we do. We collect everything from gene sequences, gene snips, CDA, social media, Internet of Things, videos, IoT, databases. Everything goes into our library. We can collect anything we want. The nice thing about big data is the marginal cost of adding to a big data store is basically zero. And that's why big data ultimately will be disruptive against existing databases. Next slide. Now, this is a key slide, which is when we collect data, you create metadata. Now, metadata, I think, is absolutely essential. So in metadata that we would collect and we store, we collect the obvious things, timestamps, where did it come from, who owns it, and then you decorate data with the less obvious things, such as version control, data agreements, sharing agreements, IP protection, confidentiality. A big one right now in Europe is locality of data. Can data travel across geographical boundaries? All of these things is what we use and we collect in the metadata of every asset that we ever put into the store. Next slide. I'll skip that. So, and then we can transform the data that we collect. So, for example, we do this routinely now. Semi-structured data, we write scripts on it and we extract information from it and create structured data. So we have several customers that will use NLP and look through medical consult letters to find keywords or keywords with ontologies that mean something in a certain context or certain use. This leads me to a second point on big data, especially analytics, is often our customers ask us to collect data for a particular use, and the use, we define how the data is interpreted. So data for one use may be interpreted differently from data to a second use. This is actually why sometimes mapping data to a standard isn't actually very easy, because it depends on the use of the data, depends how you interpret the data. Next slide. I'll give you some examples in a second on how to do this. The last thing I talk about is protecting and sharing data. Since we know where the data comes from, who uses it, who owns it, we create a mechanism where, depending on the user, their IP address, the locality, the time of day of week, who they are, what their privileges are, by time of day, etc., we can control what data they can see. We can actually alter data depending on who they are and what time of day they are. So, for example, a physician working in ER could see fully identifiable data. A physician working, same physician working in a university lab may see de-identified data. All of this is because the data itself has got metadata associated with which we can control and we can do adult supervision of data. Next slide. And so this allows us to, and we do this now routinely, support different data views for different users from the same data sets. And those data sets being aggregated from thousands of other data primary databases, such as EMR and clinical information systems. So in this example, you can see, clinician can see a fully identified patient record, a researcher sees a pseudo-identified patient record, a statistician sees population data, and the patient may see only their data set. All of this without replicating data sets, which we aggregate and federated across all of the basic input data. Next slide. So that's kind of the technology. The technology is in, it works, it's deployed. So let me give you some use cases on exactly who deploys that. Next slide. So this is a company called Molecular U. Molecular U collects brain patterns, phenotype information from heart and lymphatic system. It collects proteomic data. It collects genomics data. It does this every 3 months with blood samples, etc. It puts all of this into the big data repository, and then it basically tries to predict your future health on your molecular makeup. So it provides an early warning system for molecular screening. So this is something that's currently deployed. Next slide. Another example of this would be, so this is a customer in Africa who specialize in changing people's health outcomes by predicting what's going to happen to them in 1 year, 2 years, 5 years, and 10 years, and creating behavioral changes in those customers by knowing what's going on. This is a multi-billion-dollar company, and it collects information from claims data, from voice recordings, from customer surveys, from social media, email, streams and call center records when people dial in and talk to the health insurer. All that data is combined, and they have more than 5 million patients for this particular customer in a particular country to figure out and to change people's behavior. And this is one of the fastest growing companies in the world right now in terms of changing the cost of healthcare by predicting what's going to happen next. And they use this big data behind the scenes a lot to figure these things out. Next slide. So this is an example of something we're doing in British Columbia, finding targets for cancer patients. We have cancer data in British Columbia that goes back to 1969 of every cancer ever collected in British Columbia, and mining that to find targets of cancer patients and to map the genotype and phenotype information to do some better predictive analytics is a key strategic move of the guys in BC. Next slide. This is another example of something we do in BC. We spend $1.6 billion a year in diabetes in BC. So we're currently aggregating 13 different data sources, which are census data, discharge data, patient assessment data, phenotype data, EMR data, genotype data to change that $1.6 billion cost of diabetes and take 10, 20, 30% of the cost of this. And I, like Kirk earlier, big fan of John Snow, who was in fact the father of modern epidemiology, and we have some of the 5 best epidemiologists in the world just essentially working on this to change the outcome for these diabetes patients, which is, by the way, our number one issue in BC. Next slide. This is another example of things we're doing. Is a connection between autism and the microbiome in the gut. So we're collecting genotype information again, microbiome information, EMR, phenotype information, and education information in this case, combining this with also patient observations to provide information to researchers, to clinicians, to GPs, and to families on the progress of autism going forwards. Next slide. This is something we're asked to do a lot, which is, can we collect data from these thousands of data sets and manufacture data sets for different uses? Data masks, data cubes, tables, applications, structured data for research environments, interpreting data in different ways for different people. So it's the ability to manufacture data sets so that we can control privacy and security in a particular controlled environment is actually resonating now across the world. Last slide, I think. Next one. Okay. So a big issue with big data is one can start quite small with big data. One can grow big data. It exists with your information architectures today. You can actually pull data and not alter your primary data sources. You can combine the data and merge it, and then you can manufacture data sets for your data scientists, your privacy stewards, your physicians, and your patients. And enough to say that around the world, this is taking off a lot. We do a lot of work right now in Africa, in England, in China, in Canada, and in the US. Okay, so the last slide, I think. Is that the last slide? Okay, here we go. Okay, so I'll turn it back to the moderator for questions.
All right. Thank you very much to Trent, Kirk, and Paul for your presentations. And thank you very much to the audience for all the questions that you submitted. So let's get going with those. The first question, probably Trent, you can answer this, but I'll open it to anyone. who can access the data that you're collecting and making available to PCoreNet? Can a pharma sponsor mine that data to assess how the patient population is doing?
Thank you. Yes, that's a great question. The current way the infrastructure is set up and the governance and agreements that are in place, anyone can access the data, but not directly. We partner with them, either ProCoreNet partners with them, or we as a CDRN partner with them. We help them formulate the question in a way that the CDM, the clinical data model, structured data warehouse, can answer. We make sure we have a local partner to handle any issues of things like IRB, et cetera. And then we make the data available that way. There's also a cost involved, mostly paying for personnel costs, since the infrastructure is all up, but the idea is to make it as inexpensive as possible relative to traditional research.
All right, thank you. The next question is for Kirk. What data standards like HL7, LOINC, SNOMED, other health languages are most useful in feeding big data? How could data standards be more helpful in linking disparate data sources?
You're going to have to read that question again. You kind of cut out there.
Okay.
Sorry.
So sorry. Once again, what are the data standards like structured HL7 messages, LOINC, SNOMED, other health languages are most useful in feeding big data? How could these data standards and health languages be more helpful in linking disparate data sources?
Well, that's a great question. In our case, we use, of course, all those data standards that are mandated by meaningful use in ICD-10, kind of our core. We use SNOMED.
Kirk, we lost you.
Can you hear me?
We lost you for a second.
Yeah, I'm having some sort of technology glitch here. To make them more useful, let me kind of back into that. That we find what is least useful to us are we ask common questions, and because we don't have our own standards or there aren't standards, we can't answer them correctly. And let me give you an example of one that happened that we are arguing over. One has recently been, what is a clinic? There's no sort of standard definition of that. To the CFO, a clinic is something that produces a P&L. To a doctor or a nurse, that's where they go to work. And to a patient, that's where they call to get an appointment. So, also some of the reports, for example, what is patient volume? That means different things to different people. So, some of the things I think that we take for granted is especially in terms of sort of basic reporting, I call it rows and columns, that we need to standardize internally based on our sociology and our practice would be most helpful to us. And that's where we struggle. We struggle the most, are dividing those internal standards for our own operation.
Yeah, this is Paul, if I can jump in. Defining a standard for something is actually very difficult, and to some extent, in the limit of fool's errand. So, for example, age. What is age? We'd all think an age is at a certain time you've been alive, but in the insurance industry, there are 5 different definitions of age. There's actuarial age, there's physical age, there's mental age, and they use those 5 very, very differently. So, in fact, it's how you interpret the data depends upon your definition of the data. In Canada, there's the word inoperable. So somebody could be inoperable for heart surgery. The inoperable means different things in different hospitals. So when you actually look for that particular word, you're never going to get every hospital to agree on what that means because they have their own definitions for it. So when you're looking at data and you're looking at outcomes, it's very important to know what inoperable means at that hospital compared to a different hospital. And so reading data is where you interpret the information that you have.
I will. This is Kirk again. I will add one thing. This is again an internal policy. I mean, that's exactly right. The sort of the internal rule that we have for ourselves is we can't name something the same thing. So we can't. If we have something called age, it can't mean, if you want to call it chronological age, it's got to have a different name. So I know that's a very simplistic and self-evident rule, but it's a rule that's very important to follow once you start devising these standards. Your nomenclature becomes very important, and the political will to enforce that nomenclature is probably the most difficult thing.
One last question. I guess we're getting over time here, but how much evolution is happening in the realm of data science? Are healthcare providers pushing vendors to develop better and more intelligent tools?
This is Paul. I would say yes. Certainly, the days of just querying a data warehouse to find an answer are basically numbered. A lot of the stuff that we get involved in asks a question and wants to answer a question. And answering that question involves more than a lookup. In other words, it involves some interpretation of the data, quite a lot of data science, maybe some pattern matching, maybe some machine learning, maybe some trend analysis. All of this requires data science. And to that end, we actually have a data science course that I teach on, and the number of students coming through those courses is rising exponentially as people start to dive into healthcare and policy from an informatics perspective and want to figure things out rather than just query a database.
I'd like to add to that, in that a lot of the people, there's a big difference between a management report and analytics in my mind. You know, a management report, whether it's a dashboard, whether it's real time, is retroactive. But the big difference is you're looking for cause. You know, and a dashboard or a management report or a query really relies on the expertise of the manager looking at it to do something. Whereas true analytics, in my view, where we need to get to and what we are not adequately training for is the discovery of cause and the testing of cause using the scientific method. So I can't emphasize that enough, and how sort of disturbing it is that getting a report is not hypothesis testing, intervention, and then testing it again. So this search for cause is very, very important.
I agree, and that's one of the reasons why we're spending a lot of energy thinking about ways to do robust, hypothesis-driven, reproducible, large-scale research with these infrastructures.
Well, I'd like to thank everyone for their time today, especially our presenters and PHEMI, our sponsor. We couldn't get to all the questions that everyone sent in. So if you can send an email to claudia.ellison@ehidc.org, we'll try to get back to you and answer those questions. Wonderful opportunity to discuss these problems, how far we have to go, and the great progress that we've made.
Thank you, everyone.
Thank you, everybody.